you're still thinking about endocrine and what you did or didn't know about endocrine. Somebody said this test was hard. For me, it's a lot of material that you have to understand, because if you don't know hypo from hyper in these different endocrine glands and disorders and nursing management and pathophys and all that, you can't really fake it. It's just not one of those kind of things where test taking alone can get you by. But anyway, so we'll post the scores today. So let's think. Spring break is coming. Everybody needs it, including me. I'm actually going to San Diego in a couple days to plan a wedding with my daughter. She actually lives in Oakland, San Francisco, but she was born in San Diego. I actually taught nursing in a community college called Southwestern Community College in Chula Vista, California, which is on the Mexican border, South Bay, San Diego. So I lived there. I was a Navy officer wife. I lived there for 6 years. My daughter was born there, and I taught nursing there. So it's kind of my other favorite place to go. And I know the place probably better than I know DC.
Go to a wedding there next year.
I'm from Baltimore, but I've lived a lot of places as a Navy wife. Also, I told you in the beginning that I do have clinical background with the National Cancer Institute doing clinical trials on cancer treatment. And the OCN, after my name, is my certification from the Oncology Nursing Society in Oncology Certified Nursing. So this now, the rest of the course, is my favorite stuff, if you will. I like teaching all things. I like all parts of nursing. I love doing spinal cord injury rehab, etc. But for competency 10, 11, and 12, this is my area. I love to teach this stuff. Competency 10 and 11 is together on the PowerPoint. So those of you who brought your PowerPoints for starting competency 10 today, they're together. We will begin to talk about cancer concepts now, sort of the introduction to these competencies. When you come back from spring break, now you'll have time, hopefully, to think about competencies 10 and 11. The labs this week will be on breast cancer, so we're starting the oncology content in the labs as well. When you come back, we'll do the rest of competency 10, and then the week after that, we'll do competency 11, and the week after that, you'll have test 4. Okay, so it's still, a while away, and you'll have time, and I don't know whether you'll have time to look at things over spring break, but it does hopefully give you a chance to at least review your materials. So here is the information, the concepts for competency 10 and 11. Which is basically everything you need to know for test 4. To me, and you may not agree, test 4 is the easiest test in this course. Not test 3, but test 4. Because it's pretty straightforward and it talks about this information, which we're going to do in class, which you're going to read in your IGGI. And it's a lot of different readings in IGGI because the content for the different cancers are in the chapter that relate to that body system. So there's a breast chapter, there's neuro, there's GI, there's the hemopoietic cancers, leukemia, lymphoma, myeloma in a different chapter. And you have a lot of stuff in your study guide. So if you open your study guide to page 127, 128, 129, you'll see the objectives for competency 10. So competency 10 will be about cancer concepts. We may get to touch a little bit today on brain tumors. We'll do breast cancer, lung cancer, colon cancer, and skin cancer. And that's competency 10. Competency 11, we'll talk about the blood cancers, the systemic cancers of the hemopoietic system, leukemias, which is cancer of what?
The blood.
Which ones?
The
The white blood cells, right. Lymphoma is cancer of the lymph system. And multiple myeloma, you saw that when we talked about the diagnostic procedures and we showed you those PET scans. It's plasma cell carcinoma of the bone marrow. Okay, so that's competency 11. And that's it. That's a lot, but it's what you need to know for test 4. After we take test 4, we're all going to meet together, the whole 2020 class, and competency 12 will be taught in 1418 by me when we talk about chemo, okay? Well, not just chemo, but chemotherapy and radiation therapy as part of the cancer treatment modalities. Competency 12 is not on test 4. Competency 12 is on the final exam, along with everything else. But the final exam has a lot of questions from competency 12. Okay? All right, so yeah, we still have another test and a final in this course, huh? So the other thing I want to point out in your study guide is not just the information that goes with competency 10, although it does have the objectives. It has the outline view of the PowerPoint for you. And on page 140 and 141 and 142 is a case study. Okay, a patient with breast cancer. We're going to talk about that probably next time. I'm not going to say next week because we're not here next week. On page 143, of course, you have your vocabulary, which is always critical to know those terms. And on page 144, 145, there are two of these pictorial concept maps, if you will. One about post-mastectomy and one about melanoma. Now, in the back of your study guide, some of you may have put it with your other stuff, I want to point out page 249. And I'm happy to see this thing right in front of you. Right? It looks like this. Okay? So I know that many of you, as part of your study skills, like for today's test, you make something like this for yourself. Well, we put one in here for you. And it's blank intentionally. And it's blank intentionally because if that box is relevant, which it isn't for everything, these are the things we want you to know about these cancers. It's not all cancers. It's page 249 in your study guide. From this point to the back of the study guide is all information, handouts, charts, etc. for the oncology nursing content, the rest of this course. The rest of this course will be on oncology nursing, which is obviously care of the patient who has and is receiving treatment for cancer. Right. Okay. So across the top, brain, lung, breast, colorectal, prostate, and skin are the cancers. And then down the left column, it tells you risk factors, because we want to know the patient's what? Risk profile. What are their modifiable and non-modifiable risk factors for developing these certain cancers? These are all solid tumors, because there really isn't any surgical treatment. For many of these cancers, one of the primary treatments would be surgery by a surgical oncologist or a breast surgical oncologist that just does breast cancer surgery. When in doubt, cut it out, right? That's surgery. And then we're also going to talk about other treatment modalities, adjuvant chemo or radiation therapy, for example, in addition to surgery. One of these cancers you've already studied. You may not remember, but you did. Which one of these cancers did you already study?
Prostate.
Prostate. Okay, good. So you don't really have to fill that out, but I think it's important because when we talk about the top 4 in incidence, the big 4 in numbers of people who get them, prostate is one of them. And what are the other 3? Breast, lung, and colon. All right. The American Cancer Society, thank you, the organization that does cancer research, advocacy, and patient support, is American Cancer Society website is cancer.org. Easy enough, right? You might want to go on there over the next week or 2 or 3 and look at www.cancer.org and look at some of the information and support that the American Cancer Society provides for patients, for families. They try to focus on patient support, but they also do have some professional education that they provide too. Along with the ONS, which is the Oncology Nursing Society, and they have a lot of good stuff too. Professional information for nurses, for oncology nurses. Okay, that's where the OCN comes from. I took their test. Actually, I've taken it every 4 years since 1988. So are your testing days over when you graduate from this program?
No.
Because if you want to be certified, you want to get your BSN, you want to get your master's, I mean, you know, it's never over. You're always being evaluated, you'll always need testing. Anyway, that's the Oncology Nursing Society. The other good website is, this is through ASCO. ASCO is the doctors, the American Society of Clinical Oncologists. Oncologists, of course, are the physicians that prescribe the chemo that take care of patients with cancer. It wasn't that many years ago, I guess because I've been a nurse for 40 years, and maybe in some of your places you've lived, where there were discussions about whether to tell grandma that she had cancer, because we didn't want grandma to know. Well, that's because, well, for one thing, it didn't work, because as soon as you would leave, the family would leave, grandma would go, I know I have cancer, but they don't want me to know. Grandma knew. She knew what she had. And now, in this country, in this world, other parts of the world too, they have grandma's doctor is called an oncologist. So grandma's doctor is an oncologist. What does grandma have? Okay, so we are not afraid to say the word cancer. It's not contagious. Nobody in the scientific community has believed that for a long, long, long time. Okay, so we got to get at least past that, because that kind of thing, misinformation, fear, is usually based on lack of information, and it causes what? It causes stigma. We still have some things in some communities that are stigmatized. Hopefully cancer is not one of them. I think the one now really is some of these mental illnesses. Even though we know they're brain diseases and we know the neurochemistry and we know the biologics and we have the medications, there's still fear and stigma, mostly, with a lot of the mental illnesses. But hopefully not with cancer. We have oncologists, the medical oncologists that prescribe the chemo, they belong to ASCO. This is their, an interesting, it's not their only website, but this is one they've developed called www.plwc.org, People Living with Cancer. So again, like ACS, it has a lot of good information and advocacy and support and connections to clinical trials and all that kind of stuff for people that have cancer. So these are all legitimate, professional, or ORG websites for people, for nurses that work with cancer patients, which you all have and will, or for your families who have cancer. So the non-modifiable risk factor that we really know now is genetics. So the latest Angelina Jolie story, several years ago, she was tested and she had the mutant susceptibility gene for breast cancer, BRCA1, BRCA2. So she had like a 60% chance of getting breast cancer, and all of the women in her family have died of breast cancer. So she had a bilateral prophylactic mastectomy. Recently, she had another blood test and found out she has a high genetic risk for ovarian cancer and has a family history of that. So she's had her fallopian tubes and ovaries removed, again, because she would rather be proactive and live without those things and watch her children grow up and that sort of thing. She's had the money for the genetic testing, which is probably not covered by insurance, although we're trying to get there. But she also has information, and she also has support, family support, and people that understand her situation, and doctors that supported her decision and did the surgeries. Right, exactly. So but all of that is important. All of that, anybody can get information. Anybody can make decisions for themselves or their family based on information. With the doctors, if it was a crazy idea, the doctors wouldn't have done it. Or maybe they would have shared enough money. There's some crazy doctors. But these weren't crazy doctors. These were people helping her make these decisions based on her high risk profile. Okay. The other thing I wanted to mention, which is not an assignment, but the Public Broadcasting System, PBS, is running a special. I bought the DVD, thank you, Jess, but it's not going to be out till the end of April. But next week, Ken Burns, who's wonderful, has developed a 6-hour, 3-part documentary based on a Pulitzer Prize-winning book called The Emperor of All Maladies. Now, I've read the book, and it's fabulous. And what it is, this PBS documentary, is the history of cancer and cancer treatment in the country and the world. It's called The Emperor of All Maladies. I love the name. It's written by an Indian oncologist who's in this country. He's Indian ethnically, but he's an oncologist. And he wrote The History of Cancer and Cancer Treatment. Now, it's really cool to me because I'm old and I worked for the National Cancer Institute, and we did clinical trials on new chemo drugs back in the 1970s when we actually believed that if we had, this is 1970s, if we found the right combinations of chemo drugs, these cell poisons, these anti-neoplastic cytotoxic drugs, and we put them in the right doses and the right combinations, we were going to cure cancer. The President of the United States, who was Richard Nixon at the time, declared the war on cancer in 1971, started the National Cancer Institute as part of NIH, and gave millions of dollars to those of us, the smartest young doctors, these, university graduate nurses like me, working to try to cure cancer with chemo. Now, that didn't work. We cured some cancers. We cured Hodgkin's disease. We cured acute lymphocytic leukemia in many children. But we didn't really make a huge impact on the big four: lung, breast, colon, and prostate. Now we have, and this goes on through the history of cancer and cancer treatment in this documentary, we have more genetic testing, like Angelina Jolie had available to her, and we have more targeted therapies that actually go in and target the mutant gene in the genome. We now have mapped the human genome, right? So now people can get their cancers not just tested for the cell type and all that, but the genetics, and find the mutations in the tumor, and then target the treatment to the mutant genes in the tumor. It's not widely available, but it's coming. And that's what these targeted treatments are. Okay? So again, that's kind of my beginning introduction. So all the rest of the handouts in your study guide, which I know people probably didn't prepare because you had a test in something else today, but over the next 2 weeks, go through your study guide and look at the things that are provided for you in the appendix that'll help you with competency 10, 11, and 12. Okay? Because now we're going to talk about oncology nursing. One group here, you're the only group really, who has the benefit of being on an oncology unit in a big hospital with a lot of resources, Anne Arundel Medical Center in Annapolis, and the DeCesaris Inpatient Cancer Center. They also have a lot of outpatient services. They have a lot of oncologists in the community. They have about a 40-chair infusion center, which is in a different building. Maybe I could get you guys over there to see that. But that's where they do a lot of chemo. A lot of cancer treatment is now done electively. Patient decides or not, and it's done as an outpatient. It's done in the oncologist's offices by the chemo-certified RNs. It's done in the hospital infusion centers by the chemo-certified RNs. It's done in the home with home care by the chemo-certified RNs. So here's where I'm going with this. Who gives chemo? RNs. RNs who have been through the ONS chemo certification information.
They give it a lot at the bedside too.
They do.
Anne Arundel.
And those are chemo-certified inpatient nurses who are then trained to give the chemo. Oh yeah, absolutely. It's given as it's a lot of it is given as an outpatient. Kind of my point. But when we used to bring people into the hospital just to get their chemo, there are a few chemo protocols now where they put them in to do inpatient chemo, and they're just there for chemo. Not as many as there used to be. There are still a few, and you'll see that in Anne Arundel Oncology Unit. Sometimes they're just there for chemo. Mostly they're there because they're sick and they have other complications of their cancer or their chemo, but they're giving them chemo while they're in. Yeah, that's true. Okay, good. So number 1 through 5, diseases, causes of death in this country today. Number 2, of course, is cancer. Malignant. If something's malignant, it's cancerous. If it's benign, we can get different kind of lumps and bumps that grow in our bodies, but if it's benign, it's not going to spread. It's not malignant. Even benign masses can become a problem. But if it's malignant, it means it has the chance of spreading. And the word for spreading is what?
Metastatic.
Metastatic or metastasis, right. That was my joke is you got to be able to say and spell metastasis. I've got these new Invisalign braces that are making me crazy because I'm lisping. But, okay, so metastasis, which has a lot of S's, is when the cancer spreads, right? That's a malignant kind of tumor. So that's the number 2 cause of death in this country. Number 1 is still cardiovascular or heart disease. But, they're pretty close. We're making some inroads. There has been a slight decrease in the death rate for cancer. And we're starting to do better with some of the primary and secondary prevention and a lot of the treatment for heart disease. So they're the big two. Of the incidence of cancer, in men, the number one type of cancer is what?
Prostate.
Number 2 is lung. Number 3 is colorectal. What's the number one cause of cancer, or type of cancer rather, in women? Breast. Used to be, I learned years ago that it was like 1 in 22 chance that a woman would get breast cancer over the course of her entire lifetime. Now we're saying 1 in 8. I remember 1 in 22, 1 in 16, 1 in 12, 1 in 10. Now it's 1 in 8. So the incidence has doubled over the past 30 years. We're not sure what all the possible causes of that are. Some might be better detection and diagnosis, because perhaps women died of advanced breast cancer years ago and didn't know that's what it was. But we also have some kind of environmental concerns and exposures that we'll talk more about in lab today or tomorrow, and we'll also talk about when we come back from break. Number 2, by incidence, is colorectal. Number 3 is lung. So these are what we call the morbidity statistics. The next slide is the mortality statistics. So more men get prostate cancer, but the number one cause of cancer death in men is lung cancer. More women get breast cancer, but the number one cause of cancer death in women is lung cancer. Okay, so here's my question to you. Why do you think, or what about lung cancer makes it the number one cause of cancer death in men and women?
Smoking.
Because the way it spreads, insidious.
Well, breast and prostate, they have screening things for it.
That's good. That's part of it. Okay, so there's a couple things I heard you say. I wanted you to get a chance to say some things and think about it. Let's go with that concept of secondary prevention first. The concept of secondary prevention is to do screening for what purpose? Early detection. To find it in its earlier stages where it has the best prognosis. Okay, good. So we have secondary prevention or screening for prostate cancer. What is it? PSA, the tumor marker, prostate-specific antigen, and the digital rectal exam. Good. Breast cancer, we have secondary prevention for that, and what is it?
Mammogram.
Breast self-exam, clinical breast exam yearly, and a mammogram, right? Okay. Lung cancer hasn't really had in the past a good sensitive screening test that makes it have good secondary prevention. So because of that, many people with lung cancer are diagnosed when they have symptoms, and by the time they have symptoms, they're already in stage 4 advanced lung cancer. So the prognosis hasn't budged too much over the past 50 years. Also, it's part of the characteristic of lung cancer. Lung cancer tends to be, cell-wise, more aggressively growing than prostate or breast, especially prostate. That's more of a slow-growing cancer of old men, whereas lung cancer it tends to be a more aggressive type of cancer. Oat cell carcinoma of the lung, which is small cell CA, tends to be considered metastatic at time of diagnosis. What do you think the first symptom of lung cancer is? A cough, chronic cough. But what are these people also doing at the same time? They're smoking. Huge risk factor. We know that smoking has a high incidence of causing lung cancer. Does everybody who smoke get lung cancer? No. Does everybody who has lung cancer smoke? No. But there's a huge correlation between years of smoking, pack years, how many packs a day times how many years, and the development of lung cancer. So it tends to be a more aggressive cancer. It's often diagnosed in later stages, and the prognosis isn't as good. So we're going to talk about lung cancer more in 2 weeks too, and I'll tell you about some of the new clinical trials for taking high-risk people, smokers, and doing screening, doing regular spiral CTs of the chest. And yes, they have found with this study that they've picked up some early lung cancers in some of these guys. And it's really been kind of exciting data. Okay, so, and if you're on that oncology unit, you see a lot of guys in their 50s and 60s who now have lung cancer. And women, yes.
Do insurance companies normally The prevention?
That's the next step. In the study, they are, the people that are enrolled in the study. Dr. Catania and the guys at Anne Arundel they have money for their study. And it's a nationwide study. So just like when people came to us in the National Cancer Institute, everything was now free because the government was covering it all. Same with these clinical trials. It's still in the study phase. So people in the study, yes.
Is there a lot of insurance companies and a lot of insurance are helping with smoking cessation?
That's the
Because
other
they are,
piece of it. That's the other piece of it. That's what Dr. Catania told me. He said, well, this is very nice that we're trying to pick it up early, but wouldn't it be nice if we could keep the people from falling in the river upstream so we didn't have to keep trying to rescue them downstream while they're drowning? We got to have people stop smoking. And so smoking cessation is part of the whole picture of lung cancer prevention. If they didn't smoke, and plus it's never too late to quit. Don't start, but if you did, stop.
If they have a program with insurance.
They do. It's way cheaper to do
They'll drop your
prevention
insurance if you go to the
than to
prevention.
treat the patient once
Yeah.
they get cancer. And heart disease and all the other things smoking causes, which we know. Okay, all right. All these years, cigarette companies tried to say it wasn't going to cause cancer.
And CVS doesn't sell cigarettes anymore.
And CVS doesn't sell cigarettes anymore because they're in the wellness business now, and that's really, I think, a smart business decision. Yep. Okay. The other drugstores still do, so we'll see. Good. All right, so we got you thinking here a little bit. Cancer prevention. Okay, so we talked a little bit about secondary. But let's go back through this, make sure you understand. Primary prevention is what you do so you don't get sick, right? Okay, so we know that with cancer as well as other diseases, it's really important to know your risk profile and that of your patients. Meaning, you need to know what their non-modifiable risk factors are, which are what? Say them again. Genetics, age, gender. Yeah, the cancer, the risk of cancer increases with age. I mean, we all develop funny little aberrant DNA mutant cells, but our immune surveillance kind of zaps them. So if people who are immune compromised, there's a high incidence of certain cancers, say in HIV patients, or they're getting really old and their immune system is weakening, the incidence of cancer increases with age. Yes, there are pediatric cancers that you will study. So any living organism that replicates cells can get cancer. You know, babies, kids, any age people, doggies, kitties, plants, right? Ever seen a tumor on a plant? Sure. Anything that replicates cells can have aberrant DNA that develops. Okay, and this genetics breaks down in the cells. Cancer is a disease of aberrant genetic signaling pathways. We know that now. It's a disease of abnormal genetic signaling pathways. So it's all genetic. Are there carcinogens that can set that off? Yes. Exposure to things. We know a lot of cancers and what the exposures are that can cause it, like smoking and lung cancer. By the way, smoking causes other cancers too. I saw a Kaplan question once, and it said, which of these is associated with smoking? And it had these cancers, and lung wasn't there. And it was, the answer was bladder. Bladder cancer increases risk with smoking. Pancreatic cancer, kidney cancer, all those are higher incidence with smokers. We always think of lung, but that wasn't one of the choices. Okay, so primary prevention. What you do so you don't get sick. So the big thing, of course, now is lifestyle. Is diet, exercise, maintaining a normal weight. There was some nutrition thing upstairs there yesterday, and it had a poster, and it talked about decreasing your risk of colon cancer through diet. So what do we tell people they should eat?
High fiber.
Fiber,
High fiber.
cruciferous vegetables, broccoli, kale, well, not kale's not cruciferous, but vegetables. Kale's big right now. Broccoli, cauliflower, green vegetables, a high fiber diet, so the poop doesn't sit in there in your gut for a long time and putrefy and cause toxins. Okay, so you want a high fiber diet. So diet and exercise. Pardon me?
When are they going to lower the prices of those?
Well, they're not, because the farmers cost a lot of money to grow them. And then we get into the organic vegetables that don't have the pesticides, and they're even more expensive. So we do have problems with things like what they call food deserts, particularly in low-income areas, where the cheap comfort foods that are bad for you are widely available. That stuff with the fat, the sugar, and the salt, and the fresh vegetables and fruits are a problem, yeah. And also they cost money. That's true. But some of you came from countries where you actually ate fruits and vegetables and you didn't, and other than putting them in, frying them in grease, which not everybody does, but they were fresh and you cooked from scratch.
Yes.
And you didn't go, your kids didn't eat from the McDonald's drive-thru every day. They really didn't. Okay, so that's diet and lifestyle modification is primary prevention. And I guess if you want to get, somebody always asks me this, if you want to get really technical, but I don't want you to get confused, Angelina Jolie removing her breast, the bilateral prophylactic mastectomy she had, would be considered primary prevention.
Yes.
Because if you don't have breasts, it decreases your risk of getting breast cancer. So you don't get it. That would be primary. Now, secondary prevention, think of that. What's secondary prevention? You said for breast cancer, it's breast self-exam, mammogram, and a clinical breast exam. Is a mammogram going to keep you from developing breast cancer?
No.
So that's not primary. All of the screening. Now, in your study guide, on page 250, I want to prove to you I didn't make this whole thing up about the levels of prevention. At the top of the page 250, I showed you page 249. That's your blank study chart. Risk factors, symptoms, diagnostic tests, surgical procedures, some kind of ectomy or otomy, post-op positions, and any other special considerations you want to write in that box. The next page, and I have a couple pages here that comes from this cancer concept stuff. Page 250 at the top says what? ACS, which is the American Cancer Society Secondary Prevention Guidelines. Under that, it says, American Cancer Society recommendations for the early detection of cancer in average risk asymptomatic people. That may be you. Actually, for me, I have some increased genetic risk for some kinds of cancers. So I'm not average risk, I might be high risk. That way, I might need to get my colonoscopy before I'm 50, if my father or grandfather had colon cancer, one side and the other. That's true. Breast cancer. I may need my screening mammogram, even though I'm fine, before age 50, because I have a genetic risk. So I'm not low risk in those two cancers. But these are the ACS recommendations for screening.
With breast cancer, isn't it if you get it, so it's not genetic if you get it young, right? Never say, something.
don't go there.
So there's nothing.
No,
like
there's
that.
no absolutes in any of this. See,
Okay.
I'm going to say that the incidence of breast cancer increases with age.
Okay.
But there are women like Angelina Jolie who have a family, a genetic history of premenopausal breast cancer, and they have the mutant gene, and yes, it is genetic.
Okay.
So as a matter of fact, the younger people tend to have the more genetic cancers, and they do tend to be more aggressive. The old people, sometimes it's just things have worn out and they have their immune system is not as good.
Okay.
But you can't, there's no absolutes, because you can get a genetic breast cancer in your, family history of postmenopausal breast cancer. So I can't tell you that it's early or late, it's genetic.
Okay.
It can be any age and be genetic. Because cancer is a disease of abnormal genetic signaling pathways, and that can happen at any age, but your family history makes that more likely. Okay, I was a little off subject, but so secondary prevention is screening, right? And that's what it says here. Breast, colorectal, prostate, cervix. These are some cancers that we have widely available secondary prevention for. But the point that we made a little while ago was not all cancers have secondary prevention or screening. Some of the ones like pancreatic and ovarian and lung, up until recently, lung, and kidney, those are hard to find in early stages because we don't have sensitive, available screening. Okay? All right. And then tertiary prevention. This is all about rehabilitation. It's about preventing complications of people while they're that have cancer while they're undergoing, say, treatment. And all this survivorship. There's actually a nurse at Anne Arundel. I don't know if you've met him. His name is Matt. And he just took one of the new nurse navigator positions. They have nurse navigators at Anne Arundel for all different kinds of cancer. Breast cancer navigators, lung cancer navigators. He's actually the cancer rehabilitation nurse navigator. He's a great guy. He was a floor nurse. He actually had a terrible car accident in Wisconsin. His wife was killed. He had a bad brain injury. He went through brain injury rehab himself, got himself almost back to normal, and instead of doing a staff nurse position on the floor, they've given him this rehabilitation nurse navigator position. So if you see Matt, tell him I said hi. But he's working on rehabilitation of people who have had, say, extensive surgical or other treatments for their cancer. So here's an example of, I guess we talked about this. See if I already told you this. Tertiary prevention for a patient who has had a mastectomy post-op.
What's the lymphedema?
We want to elevate the arm post-op mastectomy to prevent a possible complication called lymphedema, right? So that would be an example of tertiary prevention for cancer. Elevating the arm after mastectomy, which is, of course, removal of the breast, in a patient where that's for treatment for breast cancer. To prevent a complication called lymphedema is an example of tertiary prevention. Okay? Because what you're preventing in tertiary prevention is what? Complications. That's a magic word. There's like a magic word in each level, right? The magic word in tertiary is prevention of complications of the treatment. The mastectomy is not tertiary prevention. Elevating the arm after it to prevent lymphedema is the prevention. That's what you're preventing. You're preventing complications. All right, so anybody who's ever been diagnosed with cancer and is still alive at any part of that cancer experience, newly diagnosed, undergoing treatment, cured or in remission, relapsed, advanced, end of life, those are all people that are considered cancer survivors, right? So we have a lot available now. We have nurse navigators. It's a great RN job to help people work through the system because they're going to need a multidisciplinary approach. They're oncology nurses, but they work with the physicians, the medical oncologist, the surgical oncologist, the radiation oncologist. They work with PT, OT, rehab, whatever else needs to be brought into the patients, and just to help them work the insurance and all those kinds of things. Maybe at some point hospice, all those kind of things need to be brought together because it's a pretty overwhelming diagnosis for some people, especially if it's a new diagnosis and they have to work the system to get what they need for themselves or their family, if you've ever been through that with a family member. Okay. The 7 warning signs of cancer. This is what we call a mnemonic device. The American Cancer Society this is public education, stuff everybody should know. And believe me, in this country today, most people have a lot of information about cancer. They've already looked it all up on WebMD, and they're asking you questions about stuff they looked up on the internet. This ACS, American Cancer Society, has had these guidelines out for a long time. And a mnemonic device means the first letter of each phrase spells out the word what?
Caution.
Caution. Caution. If somebody notices a change in bowel or bladder habits, it could be a GI or GU cancer. It's probably not. A sore that does not heal, maybe a skin cancer, a basal cell or squamous cell, CA of the skin. Unusual bleeding or discharge, doesn't say from where, but if it's a postmenopausal woman and she's got vaginal bleeding, that's not normal. Or a discharge from the nipple, etc. Thickening or lump in breast or elsewhere, any kind of bump or lump that grows. Indigestion or difficulty swallowing. Could be a GI or like an esophageal CA. Obvious change in a wart or mole. A change in a mole, they call them precursor lesions or pigmented nevi. What cancer would that make you think of potentially? Melanoma. Malignant melanoma. Good. And a nagging cough or hoarseness could be one of these head and neck or, of course, lung cancers. Now, that's what I mean. It doesn't mean it is cancer. But what is this caution model trying to tell people to do?
Be aware of their body.
Be aware of their body, and if they find something different,
Go get tested.
they should go get tested. They need to seek care. They need to get out of their chair, especially men, and go to the doctor. Everybody, but men are the worst. Oh, I've had this cough for 2 years. Well, what have you done? Nothing. I have this funny mole that's changed color and size, and what have you done? Nothing. So the point is, this is public education to get people to seek care if something looks different, something has changed. Is it cancer? Probably not. Could it be? Yeah. So what level of prevention does this education represent to you?
Primary.
No, secondary screening.
All right. You did you did exactly what everybody always does. And I like that. That's why I asked the question. You're looking at it and you say, oh, it's primary. And then you look at it a little more and you go, wait a minute, it's secondary. It is secondary. It is secondary because it's supposed to get people in. Now, this doesn't keep you from getting cancer. This is something abnormal that could be cancer. And so the screening you would get by going to the doctor would be for what? Early detection. This is about early detection. So this is secondary prevention education. Secondary prevention. Exactly. Good. The modalities of cancer treatment. I mentioned surgery for a lot of these what we call solid tumors. Brain tumor, lung tumor, breast tumor, or colon tumor. What we call solid tumors. Tumors that can be measured. Tumors that can be surgically removed. Hopefully early and small before they have metastasized. That's where surgical oncology comes in. So surgery can be done for diagnosis, because what's the definitive diagnostic test for any cancer? A biopsy. So you have to have a piece of tissue, or sometimes the whole lump, and the pathologist has to look at it under the microscope, right? Okay, determine whether it's benign or malignant. They pay them a lot of money. It's not 100% science. Sometimes they get it wrong, but hopefully these days they have enough tests to get it right. So it could be surgery, it could be for diagnosis. It's also very often used for treatment. It's used as a primary treatment method in a small, localized, early stage solid tumor. That was the when in doubt, cut it out. Years ago, we had these general surgeons that opened people up, fished around, and tried to fix them. Now we have board-certified surgical oncologists, including, in Anne Arundel they have 3 now, board-certified breast surgical oncologists. Dr. Taffer was the first, now there's 3 of them, and they just do breast surgery. And they just do breast cancer surgery. They're surgical oncologists. And Georgetown, which is an NCI Comprehensive Cancer Center, also has a bunch of surgical oncologists that just do breast cancer surgery. And they happen to all be women, which, isn't required, but they are.
I have a question.
Yeah.
So if you're an oncologist surgeon.
If you're a surgical oncologist,
Yeah,
you can subspecialize within that.
Well, so would you also be handling so would you ship off the chemo and the radiation to
Yes.
someone else if they need that?
Yes. If you're a surgical oncologist, you're going to do surgery. Surgery for diagnosis, surgery for treatment, surgery for palliation if it's pressing on something. But if somebody's going to determine the chemotherapy protocol and monitor the drug treatment, it's probably going to be the medical oncologist.
Okay, so they kind of work
If
together.
they're also going to recommend radiation therapy, which over 50% of cancer patients also get radiation therapy as their primary or adjuvant treatment, they'll go to the radiation oncologist. And those are specialists that just do radiation therapy. So they don't really mix and match much. If you ever go to something called Tumor Board, it's fascinating. I highly recommend it. It's free. Sometimes they serve free lunch. Tumor Board is where usually pathology runs it. And a pathologist will present a complicated cancer patient. And then all the different specialists will be there on the panel, and they'll all give their opinions. So the pathologist will say, clearly this is a Reed-Sternberg cell positive Hodgkin's lymphoma in stage 4. And I'd like to hear from everybody what you recommend. So the surgical oncologist will give his or her opinion about surgical treatment. The medical oncologist will present the chemo or the drug treatment. The radiation oncologist will talk about whether or not and how radiation therapy could help. The radiologist will show the scans and the images. And then they'll all talk about it. And the doctor that's standing up there in the front, keeping track of all this, is that patient's doctor. And that patient's doctor has come to Tumor Board to get other input and opinions. So tumor boards are really cool. And patients with oncology units all have tumor boards. And nurses often go too. All right, so the surgery is the surgical oncologist. And yes, then the chemotherapy is what? What's chemotherapy mean to you? The word just means drug treatment. So every once in a while in a book somewhere you'll see chemotherapy for psychosis. They're not talking about cancer chemotherapy, they're talking about drug treatment for psychosis. But over the years, I guess because the traditional cytotoxic cancer chemo drugs have been such a big deal, we've started calling chemotherapy meaning cancer chemotherapy, drug treatment for cancer. And we even say chemo. And we still mean drug treatment for cancer, don't we? The use of chemicals to treat, in this case, cancer. We have a whole new, maybe I just shouldn't say immunotherapy anymore. Maybe I should write biologic therapy. We have another whole category of medications, of drugs. And believe me, there's all these genetic drug companies. I should have bought stock in Amgen or Genentech 30 years ago. God, I'd be so rich. Making all these drugs, making the chemo, including the biologics. And we have biologics for other diseases too. We talked about them last week when we talked about what? Rheumatoid arthritis. You know, the Remicade and Enbrel and Humira and all of those. But a lot of that came out of the research done in oncology. Because we have biologic treatments for cancer too. We're not going to get into that. You're really just responsible for knowing, you know, that surgery, that ectomy or otomy. We're going to talk about craniotomies, lobectomies, mastectomies, colectomies, and the nursing management. That's the whole point here, nursing part. But it's interesting if you were ever get into oncology nursing to look at some of these new treatments. We have drugs called monoclonal antibodies. If the generic name ends in MAB, like infliximab, which is Remicade, if the generic name ends in MAB, it's a monoclonal antibody. Something, something MAB. Because it's, you know, just like other drugs, monoclonal antibodies also have a chemical name in their generic name. So MAB at the end makes it a monoclonal antibody. We have interleukins. We have interferons. We have the targeted therapies like the tyrosine kinase inhibitors. There's all kinds of stuff now, separate from just the old cell poisons, the old chemo. So that's a little bit of that in your book, but we're not going to test you on those. There is one group of biologics that we use a lot, and those are the colony-stimulating factors. And we've talked about those. We talked about it with renal. What's the colony-stimulating factor we use for anemia? You're right, erythropoietin, which is Epigen. Epigen or Procreate. Right, Epigen. We have a colony-stimulating factor for white cells. What's that called? Neupogen. You know, it's called granulocyte macrophage colony-stimulating factor. That's the generic name. Also known as Neupogen, which increases the production of white cells. Okay, so those are also biologics that we see a lot. And you do need to know for these competencies, Epigen and Neupogen. And then the last one here on this list is radiation therapy. The use of ionizing radiation in a tumoricidal dose. So if something's tumoricidal, it's meant to do what? Kill it. Cidal, yep, like bactericidal. Tumoricidal, in this case, radiation, is a high enough dose directed at the tumor, either externally or internally, to kill the cancer cells, right? And we'll talk about that more with competency 12. Increasingly, many cancers are treated with a combination of all of these. I had a boss when I was in Greater Southeast. I worked there for 7 years, beautiful Southeast DC. In nursing education, my boss got early stage breast cancer, premenopausal early stage breast cancer. She was in her early 40s. She had a lumpectomy, followed by 5 weeks of external radiation therapy to the remaining breast tissue and axillary nodes. After that, she got combination chemotherapy, several cycles of that, and then they put her on some other kind of targeted therapy just to prevent recurrence. Okay? I don't think she got tamoxifen, but she might have, which is a hormonal treatment. So it's very common now for people to have a combination of treatments from different doctors to do what? Give them their best possible outcome. That's all about outcomes. This is evidence-based medicine and evidence-based nursing. Believe me, the ONS does a lot of research. There's a lot of people doing PhD research in cancer nursing to look at the best ways to get the best outcome for our patients. whether you're a doctor or a nurse, you still are using these things, managing these things, monitoring these patients while they're getting these modalities of treatment to get the best outcome. And we've done really well in a lot of cancers. And so there are people, even with advanced cancer, that are living a really long time and sometimes cured. Do people die of cancer? Yes. Do people die of other diseases? Yes. Okay? So a cancer survivor is somebody living with this chronic illness. I'm going to say it again, chronic illness. There are people who are diagnosed with aggressive cancers in advanced stages where they may not have a lot of time. There are also people in remission for many years or forever. There are all parts of the cancer experience in between. But we've come a long way, and that's kind of what this special is going to talk about, from some of the things we did, many years ago, where we had children with ALL, and a doctor named Sidney Farber in Boston tried to give these cell poisons to see if he could wipe out their white cells so they would grow back normally. That was the beginning of chemotherapy. And then we've got the targeted therapies and the genetics that has really just come up over the past 10 years or so. So things continue. It's a very exciting field, by the way, to be in oncology nursing, because things continue to change. And there's always new modalities of treatment, new studies, new things like that. Okay, couple real quick slides and then we're done. I'm not going to talk about brain tumors today. You can do that for the next time with me. We know that cancer is neoplasms that can proliferate, infiltrate, and spread, producing destruction of the organism. We're talking here about human organisms, but again, it could be cats, dogs, or they even have veterinary oncologists now. I'm not giving my dog chemo, but people do. Okay, so proliferation, infiltration, and spread, producing destruction of the organism. Metastasis, we've mentioned, the spreading growth of cancer cells in a separate, distinct area distant from the primary site. Interesting thing about metastasis. If somebody has a primary, say, breast cancer, they have breast cancer, and they come in with, say, a seizure, and work them up, you see a mass in the brain. And if they could take a piece of tissue from that mass in the brain, would it look like brain tissue or breast tissue? Breast tissue. Because if it's a metastasis from a primary breast cancer, it's going to be a piece of breast cancer that broke off, traveled through the bloodstream, and lodged in the brain. There are some unfortunate people that could have two different primary cancers, but that's not what we're talking about. So if things break off and travel through the lymph system or the bloodstream, they can produce metastases. And so some tumors grow faster. They're more likely to metastasize. Some are of a higher grade, and I'll talk about that in 1 second. The host immune system can make a difference. We talked about people who are immunocompromised, like HIV, people living with HIV disease who might have a higher incidence of, say, T-cell lymphomas or Kaposi sarcoma, which is a strange skin cancer. And then there's other factors, which we actually know a lot about, but that's another day. You need to know the vocabulary. If somebody has carcinoma, it's a malignant tumor originating from epithelial tissue. Say an adenocarcinoma of the lung, breast, colon, whatever. Or a sarcoma, which is a malignant tumor originating in connective tissue, like an osteogenic sarcoma. So carcinomas and sarcomas are cancer. Most of the time, not always, because lymphoma is lymphosarcoma. If something's oma, it's benign. If you have a lump of fat that grows in your body, and they biopsy it and it's benign, it's called a lipoma. If you have a lump of fat that grows in your body and they biopsy it and it's malignant, they call it a liposarcoma. Okay? So that's some vocabulary. You're working with carcinomas and sarcomas. The staging. All I'm going to say about staging is this is a way for tumor boards and international tumor registries to look at the stage of the cancer. The T is the tumor size. The N is the nodal involvement. For example, breast cancer, has it gone to the lymph nodes, the axillary lymph nodes? And M is metastasis. Either it hasn't or it has. So T is tumor size, N is nodal involvement, and M is Mets. Has it spread to a distant organ? And we know that there are typical metastatic routes of spread. For example, breast cancer can be brain, bone, lung, liver. Lung cancer, you don't have to know this. Lung cancer goes to the brain. Prostate cancer goes where? The bone. You learned that, right? Colon cancer, what takes the blood, where's the blood supply from the colon go to first? The liver. So the first place colon cancer generally spreads or metastasizes in advanced colon cancer is the liver. Okay, T, 1, 2, 3, 4 just means it's gone from smaller to larger. We're not oncologists, so we don't need to know what the T1, 2, 3, or 4 mean in, say, a breast cancer. But obviously a T1 breast tumor is smaller than a T4 breast tumor. Okay, as the numbers go up, it gets bigger, whatever that solid tumor is. We can only use the TNM staging system for solid tumors that can be measured. Nodal involvement, N1, 2, 3, 4. If you have no axillary node involvement on a sentinel node biopsy with a breast cancer diagnosis, it's NO, normal. Now, they always put this X in there just to hedge their bet. It doesn't really mean anything, except we don't know how to assess it. N1, 2, 3, 4 would be more involvement of more lymph nodes. In the case of breast cancer, it would be how many axillary nodes. You actually have 22 of them. So if you have N0, there's none. If you have N1, maybe there's 1. If you have N4, maybe it's all 22. It has spread to. And M is basically either MO or M1. And then you say where. Okay, I'm not going to say, the last slide here is the grade. And there's no test question on the grade, because it's a little complicated. So we know about the stage, the TNM. The tumors like, this cancer's like leukemia, lymphoma, and myeloma, you can't use TNM. Okay, there's nothing to measure, it's all throughout. But for the, the brain or the breast or the lung or, the colon, you can use TNM, tumor size, nodal involvement, and metastasis. The grade is how much does that tumor cell, under the microscope, look like the tissue of origin. So a low-grade, well-differentiated, well-behaved tumor cell, say it's breast, looks a lot like a normal breast cell. That's actually a good thing. As it becomes moderately well to poorly to very poorly differentiated, we say it's becoming a higher grade. And a G4 tumor, you may not be able to tell what it started out as. Because the DNA is so aberrant and the cells are so anaplastic and bizarre, you may not know what it was. And that's bad. So the higher grade tumors tend to be more aggressive and harder to treat. We had a young guy, Greater Southeast. I think he was only 19 or 20. He came in, we admitted him to the oncology unit, which they had at the time. Alvina Bass, who some of you may know from doctors, was the head nurse of the oncology unit, and I was the educator. The only diagnosis they could ever make for him was very poorly differentiated metastatic carcinoma. They gave him, big time chemo, aggressive treatment, and he died in about 6 weeks. Never knew what it started out as. Couldn't figure it out from the biopsies because it was a very poorly differentiated, bizarre looking, we knew it was everywhere, but we didn't know what it started from. Whereas a well-differentiated or low-grade tumor looks like what it was before.
So if you're able to identify where it comes from, is it a greater chance of?
It's good to know what it started out as. It's whether, whether it's advanced lung or advanced breast or advanced prostate or advanced testicular.
Would it be a different treatment for either
Yes,
or?
because the treatments do differ for the different kinds of cancer based on research, based on the patients we studied at National Cancer Institute. And they still study at the Cancer Institute. All of this is empirically studied. It's very scientific. There's no magic here. It's science. And that's what we need to make sure our communities, our patients, our families understand about disease. Because what does knowledge do? Knowledge decreases fear. You'll see patients who said, I don't want a mammogram because I might have cancer. That's what we got to try to work with. So that people aren't distrustful of the medical system. So that people aren't afraid of getting screening. You have to have access and all that, but you also have to know. You have to be able to, make yourself do it. And I'm still working on a man over 50 to get his screening colonoscopy. That's just because he's stubborn. But we do need to be advocates for cancer care in our communities. Yes?
I'm just curious, once you have the diagnosis of cancer, is it the chemotherapy that speeds up the process? Like, you say you died with it.
It had nothing to do with the treatment. It was the disease. I've heard crazy stuff about chemo. You ever heard? I've heard all, and you may have heard some crazy things. I heard chemo doesn't work on black people. I heard that one. There's a lot of fear out there. No, the chemo was the treatment for the cancer. I mean, he did have some response to the treatment, but he had such an aggressive cancer, and it was so advanced at the time we started the treatment, that it wasn't curative. He did respond partially to the treatment. It may have extended his life a couple of weeks, but it wasn't curative. So the treatments are exactly that. They're treatments. Are there side effects of treatments? Yes. Do we have things to help with the side effects of treatments? Yes. And we'll get into more of that when we talk about chemo and radiation. But no, it was his disease that killed him, not anything to do with the treatment. Yes. Has anybody ever died of the complications of chemo? Yes. Is it very rare, especially these days? Yes. Yes. We can manage the side effects a lot better, and we have better outcomes because we're better at what chemos to give and at what doses. And that all came out of this research in the history of cancer treatment.
So is it true if you have cancer and diagnosed with it, once they do an operation or open you up, the cancer?
That's also not true. That's also not true. Has some sloppy surgeon ever pushed things around in somebody by doing it poorly? Probably. Do the surgical oncologists do that today? Very unlikely. You need the surgery to get the cancer out. Usually the outcomes are good. We have Dr. Sugarbaker at Hospital Center doing these 11-hour debulking procedures. He gets people with abdominal metastasis from all over the world. He goes in, he gets all of it out as much as he can, because they're stage 4, and then he does intraperitoneal chemo. And he dwells, just like it's dialysate, he dwells it in the belly, and people switch back and forth, and then they drain it, and it works. People that are advanced cancer in their last 6 months of life have gone on for 10 more years.
They can put radiation.
And they can also put radiation into the peritoneal cavity or other parts of the body. So it's come a really long way. It's fascinating stuff. It's really not magic. It's very scientific, and so you hear these things. And it's like, oh, Mom, don't go have your cancer surgery. It's going to spread. No, have your cancer surgery. The surgical oncologist knows what he or she's doing, and they're going to help you get better.
There's a lot of people that wouldn't have cancer surgery or wouldn't have anything to do with it. They're afraid if they got opened up.
I know that. I've heard that one for years. Not true. Surgical techniques have improved to the point where I've never heard of that happen. But that's fear. That's fear. And distrust of the medical system, which there's a lot of history in the African American community about distrust. Goes back to Tuskegee and all these other things. Yeah. That's why we need to have more people of other cultures and races and ethnic groups in the medical field, in nursing, in oncology, and that sort of thing. I worked with an African American oncologist at the Baltimore Cancer Research Center. He's at Providence now. Lester Miles. There are, that's what we need. And when he tells his patients, this is what I recommend, and this is what we should do, maybe they'll trust him more. I don't know, maybe they won't. But that's what we need to do. Yes, because we need to get past this fear of this word. Yeah. Of this chronic illness.
Consider like what she was saying, like when my daughter was diagnosed, they told me that her surgery was going to be like 4 hours long, and she ended up being in surgery for like 7.5 hours, and it was because he wanted to be careful not to spill anything into other areas. So I think it's more so
that's a wonderful
they
thing.
could make a mistake
And they don't, and they don't want to.
automatic.
Right. It doesn't these days because of the techniques that the surgical oncologists have to prevent that from happening. And that's why they were so careful. What else? So that's another whole subject, pediatric cancers, which you are going to talk a little bit about. And that's come a really long way too over the years, with like lymphocytic leukemia. Much better outcomes with all cancers. So God bless the people in pediatric oncology. I'm not a peds person. They're a special group, very special group. So if you really like peds, go into pediatric oncology. It's wonderful.
It's actually, I don't know, I guess it's
Yeah, kids are hard. Those of us who do adults are like, but we want good people in that. All right, very good. Thank you. Some of you, I guess I'll see you in lab. I guess we need to go. Go up and finish grading your last couple of questions on your test. We'll start with brain tumors next time. We have plenty of time.
Did everyone sign in?
I know you're all here because you all took the test, but if you would sign in, that would be lovely. Just in case you ever need to prove that you attended. That's really all this is about on Wednesday.
And you don't work. No, you don't.
And also, if anybody's trying to steal the pencils, would you bring it up and put it in the bag?
No.
You would never do that. No. I'm a pen stealer. I just take people's pens and walk off by mistake. If you really are that desperate, you can have
I don't have the clue that I steal.
All right, I'm bringing it.
Are you going upstairs now?
Yeah, he's already going. Okay. I'll sign for him.
Yes. Did you steal some? Did you steal?